Yes, doctor.
Okay. Hello everyone. We are yet again meeting to discuss about another topic again in obstetrics and gynecology. So today it will be a gynecology topic. So let's see. Let's see what is the topic. So one is related to, as you can see, the redness which is marked around the female genitalia. So one is related to infection and inflammation. So the first topic will be that, and the other one is related to, you can see the cysts. And a very important topic. Both of the topics are very important with respect to the examinations, competitive examinations. So one is related to the infection and one is related to the cyst. So let's see. The topic is pelvic infection and PCOS, so polycystic ovarian syndrome. So let's see one by one what it is. The aim of the session for today's session is to study about pelvic infection and PCOS. So the object is, again, not listed the objectives. So each infection in detail will be studying under the pelvic infection, and there are few inflammatory conditions also like PID, a very important sure question from that topic, and the infection part also, the varied types of infection, what are the features of each infection, what are the symptoms, how it varies from different infections. So that would be dealt. And in PCOS, the main question that is asked is usually the symptomatic picture of the patient, and the most important part will be the diagnostic criteria. So let us see what one by one we'll deal with that. So first, starting with pelvic infection. So before pelvic infection, so for an infection to occur, before that the female was healthy, right? So after from the health, the deviation occurred, and then there is infection. So for that there are barriers. So there is some physiology that is making sure that there is no infection in a female genitalia. So we will see what is that normal physiology first, so that we will get to know where the disturbance is occurring. So what are these organisms causing, the organism causing infection, what are they which physiology they are disturbing. So usually the female genitalia has a barrier mechanism where the organisms is not able to break through. So if it is breaking through, then there are few risk factors and etiology related to that. So let us see the normal. So vagina, in adult females, vagina is lined by stratified squamous epithelium. So this is an important with related to examination also. So in newborn females, it is lined by transitional epithelium and squamous epithelium. So whatever stratified squamous epithelium, it is resistant to gonococcal infection. Thus, gonococcal vaginitis cannot occur in young or adult females. So this you have to note down. So the squamous epithelium is resistant to gonococcal infection. So vaginitis, gonococcal vaginitis cannot occur in younger adult females. So vagina, this is the part, very important. So what is the normal barrier mechanism? Why it is acting as a barrier, the vagina. So vagina has local inhabitant bacteria called Dordalis bacilli, very important. Dordalis bacilli, which is also called as lactobacilli, which breaks down the glycogen present in the vaginal epithelium into lactic acid. So once it is acid, it's the pH of the vagina is acidic. So usual pH of the vagina is acidic, and the average is 4.5, average pH, and the range it occurs from 4 to 5.5. So this is the range, usual range. And this acidic pH of vagina, what happens? It will act as a barrier for external organisms. So once the external organism is trying to enter the vagina, the acidic pH is killing them. So this is the normal barrier mechanism which is occurring in vagina. For some or the other reason, this barrier mechanism is disturbed, and that is when the pelvic infections occur. Physiological discharge. So this we have to know, because what is pathological discharge of each infection, we'll get to know only if we know the deviation from the physiological discharge. So the normal physiological discharge is clear, white, and flocculent and odorless, no smell. Okay, so this is a normal discharge. And smear, if the physiological discharge smear is done, there will be only epithelial cell and lactobacilli, whereas in other infections, you can see the organisms. And the pH of the discharge, this is not of the vagina, this is of the discharge. It ranges from 3.8 to 1.2. And increases with increased estrogen state. So this pH or the discharge increases with increased estrogen stage. So when it's during pregnancy, if the female is taking oral contraceptive pills mid-cycle, that is during ovulation, and PCOS is a condition where there is increased estrogen state. So they are also, and premenarchal, there is an increased estrogen state. So here the discharge is increased. So if increased in perimenopausal women, investigate for other effects of excess estrogen. So usually perimenopausal women, there should be reduced estrogen. That is the normal physiology that occurs in a menopause. It is a hypoestrogenic state, the menopause. So it should be reduced estrogen. But if it is excess estrogen is occurring in a perimenopausal women, we should always investigate for other effects of excess estrogen. Especially endometrial cancer is one condition which occurs. Endometrial cancer is one condition which occurs in a perimenopausal women. So investigation is important here. Now, so this is the normal physiology. Now, there is something happening. Either the barrier is broken or the barrier is surpassed. So normal barrier mechanism. And that is when the infections occur. So we will see what are the common infections that occur. The pelvic common infections are, there are many, one by one we'll be dealing. This is Candida albicans, yeast infection, that is candidiasis, and then Trichomonas vaginalis and bacterial vaginosis. So candidial vulvovaginitis is the first topic that we'll be dealing, and Trichomonas vaginalis, and then bacterial vaginosis. These are the three common infections that occurs, organism infections that occurs in pelvis. So in a female genitalia. So we will see one by one what it is, and then the difference between the three also. So the first one is candidial vulvovaginitis. So caused by Candida albicans, always when infection chapter is dealt, any subject for that matter. So always remember the causative organism, because that could be a question, short question for competitive exam. So caused by Candida albicans, which flourishes in an acid medium. So we all know vagina is an acidic pH. So it flourishes in acid medium with an abundant supply of carbohydrate. So it is therefore common during. So during when it is hypo pregnancy. During pregnancy, diabetes, use of oral contraceptive pills, systemic steroids, and antibiotics. If a female is there in these conditions, then candidiasis is common in these conditions. Clinically, this is very important. The discharge, it occurs as thick white patches of cheesy material adherent to the vagina. So thick white is always related to Candida. Any Candida infection for that matter, anywhere in the body, white is the, because the Candida word meaning itself is white. So white is the characteristic feature. So don't, if the choices are given just to confuse you, but just remember Candida is white. So thick white patches of cheesy material adherent to the vagina, which when removed leave multiple petechial hemorrhagic areas. And Candida curdi, Candida means curdi, that means white. And remember, Candida lesions anywhere in the body is always white. Next, diagnosis is by microscopic examination of vaginal discharge and 10% KOH solution, which reveals candidial hyphae and buds. So this is called as WIF test or amine test. So KOH solution, it is amine. So this is also called as WIF, WHIFF, WIF test or amine, AMINE, amine test. So just remember the other names. I've always told, whenever there are more than one name for a condition or for a examination, okay, always remember the other names. And cultures with Nickerson medium may be used. So this Candida is, the culture is Nickerson medium. Next is Trichomonas vaginalis. So as you can see, the organism itself is motile and anaerobic, and sexually transmissible. So always remember, Trichomonas vaginalis is sexually transmitted disease. Usually it is an STI. It ingresses into the vagina favored when the pH rises. So this is a condition. Here the vagina should be alkaline. So pH is raised by 5 to 6, not exactly alkaline, but still it's more than the normal acidic pH of the vagina. And during menstrual period, usually the infection is prone during menstrual period. And then again, this is important, it is characterized by copious green frothy discharge. So green, just remember, which may be associated with foul odor and vulval pruritus. That means itching. So there is vulval itching, foul odor, there is bad smell, there is copious means excess discharge, and it is green in color. It is not white. White means candida, and it is frothy. The consistency is frothy here. The frothy means you all know when I assume that everyone knows what is frothy consistency, whereas in candida it was cheesy. It is sticky and cheesy consistency. On examination, this is very important, frequently repeated answer question. Strawberry cervix is seen in which condition? So examination punctuation on the cervix, classically called strawberry cervix, is seen. So just remember TR in Trichomonas, and strawberry is TR again here. So TR, Trichomonas, strawberry. So strawberry cervix is seen in Trichomonas vaginalis, just remember. And diagnosis may be made by saline wet mount of the vaginal discharge, which reveals highly motile Trichomonas. So we first sentence that we read about Trichomonas was it is motile. So if that is seen in the wet mount, it is diagnostic. And then next is bacterial vaginosis. So we will see what is bacterial vaginosis. So this is caused by an overgrowth of variety of bacterial species. So the most common organism is Gardnerella vaginalis. So this is the most common. So just remember, bacterial vaginosis, they might give you Gardnerella vaginalis, Trichomonas, Candida, many others, and they might omit these bacteroids, Peptostreptococcus, Mycoplasma, or they can form a question in such a way that all the 4 are given. So exactly 4 options are here, and 1, 2, 3, 4. So among these 4, they can ask which is the most common organism that causes bacterial vaginosis. Always remember, it is Gardnerella vaginalis, and it is all usually bacterial vaginosis is polymicrobial. And Gardnerella vaginalis vaginitis is characterized by vaginal discharge with a fishy or musty odor. Just remember. So these are all key points. So very important for the examination point of view. Fishy or musty odor with little vulvar irritation. There is something called Ansel criteria. Let's see what is it. Any 3 of the following 4 will actually diagnose the bacterial vaginosis. So increased white homogeneous thin watery vaginal discharge. So this is one thin watery white homogeneous. So it is not sticky, it is not curdy, it is not cheesy. So that is how you will differentiate from candida and here bacterial vaginosis. The second one is vaginal discharge. The discharge pH is more than 4.5. And then fishy odor, we saw in the previous slide, fishy, musty odor. So due to volatile amines such as trimethylamine, and immediately after vaginal secretion are mixed with 10% KOH. Again, 10% KOH, the test is whiff test or amine test. So fishy odor. So these are the fourth one is clue cells. So always remember, clue cells is bacterial vaginosis. And then microscopic demonstration of clue cells, vaginal epithelial cells coated with cocobacilli on a wet mount prepared by mixing vaginal secretions with normal saline in a ratio of 1:1. Just the main point key here is clue cells. Okay, the presence of clue cells more than 20%. So always remember the range, because clue cells is also present. In the previous slide we saw in Trichomonas also there are chances that clue cells are there, but more than 20% is diagnostic of bacterial vaginosis. Clue cells can be present in other conditions also. So if it is more than 20%, this range also, any range, any what to say value that is there in the textbooks or in the study materials, wherever you see, it is very important, because they can form a question easily with those ranges and numbers. So 20%, just remember, is diagnostic of bacterial vaginosis. Now we will see the differences. Again, the theory is again here we have just put it in the table. So bacterial vaginosis, alteration of vaginal flora, lactobacilli organism decrease, whereas bacilli and Gardnerella increases. So the organism is Gardnerella. In Candidiasis, the most common is Candida albicans. There are others also, Galbrata and Tropicalis. This is most common. And in bacterial vaginosis, this is most common. And then Trichomonas vaginalis, this is the only organism that will cause the vaginitis. So flagellated protozoa, this is the organism. Now, most common vaginitis overall among the three, which is the most common vaginitis? It is bacterial vaginosis. Okay, and then which is the most common vaginitis in pregnancy, in diabetes, in immunocompromised OCP users, and steroid users, and antibiotic users? We also, if these conditions are there, it is these patients are prone for candidiasis. So the most common vaginitis in these conditions is candidiasis, but overall the most common vaginitis is bacterial vaginosis. Next, STD, no. Sexually transmitted, no. Bacterial vaginosis is not an STD. We saw which is the STD. It is Trichomonas vaginalis, which is STD. And candidiasis also is mostly not an STD. And then pH, we saw the discharge pH of bacterial vaginosis is more than 4.5. So just remember Amsel criteria. If Amsel criteria is there, you should remember bacterial vaginosis. So one of the criteria there was pH more than 4.5. And in candidiasis, it is less than 4.5. And in trichomonas, it is 5 to 6. Okay, and signs. So what are the signs? Strawberry. One sign which we saw in Trichomonas vaginalis is very important. So it is strawberry vagina or angry looking vagina. So it is nothing but it will appear very reddish, strawberry, the color of strawberry. So angry means that there is any angry person, you can see the redness of their face. Okay, the congestion. So that is the way it looks is strawberry vagina or angry looking vagina. Always remember the other name. I always emphasize on that because they can easily form a question and confuse you. Okay, so the investigation of choice, IUC is investigation of choice. Here it is saline microscopy. Clue cells is very important. And as I told before, it is more than 20%. It's diagnostic of bacterial vaginosis. Vaginal epithelial cells to which bacteria adhered are seen. And again, saline microscopy in candidiasis, pseudohyphae are seen. Pseudohyphae is a characteristic feature of candidiasis. And in trichomonas, we know it is motility. Motile flagellated trichomonas are seen, or motility, just motility is seen in saline microscopy. Next, the gold standard investigation. Always gold standard investigation is an important question, especially in OBG. Any condition, if you see a line in textbook, the gold standard investigation of choice for this condition, if you see, just highlight it and remember it, because it is an easily asked question always. So here in bacterial vaginosis, the gold standard is gram stain. So gram staining, just remember Nugent scoring. Okay, on gram staining, there is something called Nugent scoring is done, and it is calculated by assessing the presence of lactobacillus, and score usually from 0 to 4 is normal, because lactobacillus is there in normal vagina. 0 to 4 is normal. Usually if it is more than 7 or equal to 7 is consistent with bacterial vaginosis. And culture on subarodes medium or Nickerson medium, this we saw. So it is the gold standard investigation for candidiasis. And for trichomonas, it is Feinberg, Whittington media or diamond media. This is gold standard investigation for Trichomonas vaginalis. And my suggestion is, because these are rare names, not at all asked in exams, so you will neglect it. No, it can easily become a question because it is a tough question. It can be a tough question. Memory is important here. So it can be a tough question. So it can be asked. And amine test or whiff test, that means 10% KOH test. So it is positive in bacterial vaginosis, and because we saw fishy or musty odor in bacterial vaginosis. So fishy odor, or because the fishy odor is because of the amine like odor obtained, and it is a negative in candidiasis. And again, trichomonas, it can be positive or it can be negative. So this finishes bacterial vaginosis, candidiasis, and trichomonas vaginitis. Now the next two conditions are, one is gonorrhea, gonococcus, and chlamydia trachomatis. So we will see what are these two. Okay. So gonorrhea and chlamydia, again, it is a pelvic inflammatory disease condition, causing organism, gonococcus and chlamydia. So you have to remember the most common cause of chlamydia is PID. Just remember this. Most common cause of pelvic inflammatory disease is a sure question for an examination, competitive examination. So, and also theory-wise also it is an important. Always remember when more emphasis is put on theory. So whichever topics are emphasis is put on theory in your BHMS course, we can see few questions are always asked from that theory questions. They will always be there in your competitive exams also, because for some reason the curriculum setters, they want you to know about that condition. So they want to know, basically it is assessing your BHMS knowledge in any competitive examination for that matter. So they want to know how well you have read in your BHMS curriculum about this topic. So it is a usually frequently asked topic in competitive examination. If it is frequently asked, that means the theory you should know very properly and concept should be clear in you. So the most common cause of PID is chlamydia. From the second most common, after chlamydia, which is the second most common cause of PID, it is gonococcus, gonorrhea. Okay, so the causative organism, always remember causative organism is Neisseria gonorrhea, and here it is chlamydia trachomatis. So it is DK serotype and obligated intracellular parasite. So it is associated with trichomonas. Usually gonorrhea is associated with trichomonas or chlamydia infection in 60% cases. But in chlamydia, again, because here you can see chlamydia infection. So here again you have to see gonorrhea infection. It is always associated. So these two are usually associated. And the most common route of spread in chlamydia is ascending infection along with sperms. So again, STI, a very important STI, is chlamydia. Okay, and most common site affected in gonorrhea is endocervix. So there is here we are not talking about STI because there is some speciality to gonorrhea. We will see later. So most common site affected is endocervix in young females, urethra and Bartholin's gland. And most common site affected in chlamydia is also again endocervix, urethra and Bartholin's gland. But gonorrhea frequently asked question is most common site affected endocervix. Just remember. And like gonococcus, stratified squamous epithelium is resistant to chlamydia also. So in the initial slides we discussed that it cannot occur, gonorrhea cannot occur in young females because squamous epithelium is predominant in young females. So again, it applies to chlamydia also. So symptoms of gonorrhea. So this is gonorrhea and this is chlamydia. So symptoms of gonorrhea: purulent vaginal discharge, dysuria, that is difficult urination, painful urination, and then frequency of urination is increased. There is no pruritus unless it is associated with trichomonas. In trichomonas we saw there is pruritus as a symptom. So but in gonorrhea there is no pruritus. And then the symptoms of chlamydia is it is insidious in onset. There is no sudden onset and it is mostly asymptomatic. So just remember, chlamydia is mostly asymptomatic, may present with, if it is symptomatic, it will present with mucopurulent discharge, and again, difficult and painful urination, frequency of micturition is increased, and bacteriuria. On culture, we see a lot of bacteria. So, it is more than I feel. It is 10 to the power of 5. So organisms per ml of urine is pathognomonic of chlamydia infection in young sexually active females. So just remember this. Okay, and diagnosis of gonorrhea is nucleic acid amplification test, NAT, of urine or endocervical discharges are done. So NAT is important, the diagnosis of gonorrhea. And the diagnosis of chlamydia, it can be NAT or PCR, polymerase chain reaction. So the gold standard investigation for gonorrhea is culture in Thier-Martin media, and gold standard for chlamydia is McCoy lines, culture in McCoy lines, and test of cure. So usually not done routinely in gonorrhea, but test of cure is done routinely in chlamydia. The main reason for it is because it is STI. So the female shouldn't be giving the infections to others. So test of cure, the female should we should make sure the female is cured completely of the infection so that it is not spread to others. So test of cure is done routinely in chlamydia. So this, if you all know, the condition is what? So is condyloma acuminata, genital warts. So we'll see what it is. So the most common viral STI. So viral, just remember, which is the most common viral STI? It is genital warts, condyloma acuminata. So the causative of organism is human papilloma virus. We all know warts is caused usually by human papilloma virus, and more than 200 subtypes, of which more than are genital subtypes. So usually more are genital subtypes, and HPV type 6 and 11. HPV type 6 and 11 are classically associated with anogenital warts or condyloma acuminata. Condyloma acuminata means genital warts. So, which is the HPV subclass of subtype of HPV for anogenital warts? It is 6 and 11. And HPV types 16 and 18. So, this is just extra information. 16 and 18 are the most oncogenic, that is cancerous. So, classically associated with CIN and CA cervix. An anatomical distribution of anogenital HPV infection is cervix is the most affected part. So cervix is the most affected part. 70% of genital warts is seen in cervix. So this could be a question. The most common site of genital warts is which? 70% is cervix. Then followed by vulva 25%, vagina 10%, and anus 20%. Next, the clinical features: soft and multiple warts or on any dermal or mucosal surface, mostly seen in posterior introitus, labia majora and minora. Genital warts can be diagnosed. How? Gross inspection, just on inspection we can see, and colposcopic examination may help to rule out other cervical and vaginal lesions which can mimic each other, and any cervical vaginal lesion it can mimic. So to rule out that, colposcopic examination can be done. And most common cause of genital ulcers in young sexual active women. So young sexual active women, genital ulcers, which are the causes? One is herpes simplex virus, HSV, and trypanosoma pallidum, this syphilis, and then Haemophilus ducrei, cancroid. So syphilis, we see a condition called chancre. So chancre is different from chancroid. Cancroid and chancre is totally different. So you just remember this difference. Now, one by one, we'll see herpes genitals. So, herpes simplex virus we saw. So, caused by most herpes genitalis is caused most commonly by herpes simplex virus 2. So, there are 1 and 2, but 2 is most common. 90% it is 2. Okay, so there is a reason. And by HSV, it is only 10%. And recurrent infection, if there is recurrent herpes infection, it is also most common with HSV 2. Sexually transmitted, again, because in the previous slide we saw young sexually active females. That means usually it is sexually transmitted, and symptoms appear within 7 days of sexual contact. And red, painful, inflammatory vesicles and ulcers in the genital area with inguinal lymphadenopathy. HSV is the most common cause of genital ulcers. So we saw 3 causes here, right? We saw 3 causes: HSV, syphilis, and cancroid. Among these, HSV is the most common. This is an important and frequently asked question. So, which is the most common cause of genital ulcers? It is herpes simplex virus. And among the herpes simplex virus, which type is most common? It is HSV2. And PCR, polymerase chain reaction, to identify HSV DNA is more specific and accurate test. And HSV1 causes disease above the belt. So we know why HSV2 is most common, because usually HSV1 is above the belt. That means it is oral lesions. Above the belt means above the abdomen. And then HSV2 causes disease below the belt, that is genital lesions. So that is why the most common HSV which causes herpes is in herpes genitalis is HSV2. And lesion first appears, again the lesion, how it appears: erythematous plaque which later forms vesicles, and then small ulcers with an erythematous halo, and then yellow base. So this is normal for any herpes infection. This is how it occurs. And ulcers are extremely tender, extremely painful, extremely tender, and inguinal lymph nodes are enlarged. And then gold standard for diagnosis, we saw which is the most accurate test. Accurate test is, which we saw before, was PCR, but the gold standard is tissue culture of herpes genitalis. The gold standard is tissue culture. So adverse effect in primary infection in pregnancy. So in pregnancy, if there is primary infection, it causes adverse effects. So increased risk of miscarriage and preterm labor is seen, and transfer of infection to neonate is also seen during vaginal delivery, and delivery by cesarean section is indicated with primary genital herpes at the time of delivery. If the primary genital herpes is to be seen during the pregnancy, C-section is indicated, because the transfer of infection to neonate occurs if vaginal delivery is done. Next is syphilis. So we all know syphilis is caused by Treponema pallidum, the causative organism, again important. And then primary syphilis, we all know primary, tertiary, and secondary. Primary, secondary, and tertiary syphilis are there. So after a few slides, we will see, I have made a table where there is how it is presented. So primary syphilis presents as hard, painless, solitary canker. So on the vulva, vagina, or cervix, although non-genital lesions may also be present. So chancre is very important in syphilis. And then non-tender inguinal lymphadenopathy is present. Primary chancre resolves spontaneously within 2 to 6 weeks. And then molluscum contagiosum, again, pox virus is the causative organism, most common in developing countries, and most common route of spread is skin contact. It can be sexual or non-sexual. Characteristic lesion is multiple dome-shaped papules with central umbilication, and diagnosis is bypass inspection. So these are all just you have to go through. It can be a question. And then the next is very important part where the questions are asked, pelvic inflammatory disease. So inflammation, we know this is nothing but itis, that means vaginitis or cervicitis. So we will see whether they are included in pelvic inflammatory disease. So others like salpingitis, endometritis. Let's see, uveitis, we will see what it is. So the definition is infection or inflammation of upper genital tract. So that is why I told, let's see if cervicitis and vaginitis are included. Usually in pelvic inflammatory disease, cervicitis and vaginitis is not included. Just remember, this can be a question. It can be a question which becomes like statement 1 is right, statement 2 is right, like that. Questions can be framed from this. So upper genital tract, including ovary, that is uveitis, fallopian tube, salpingitis, uterus, endometritis. So these are the 3 inflammations that occurs in PID, whereas cervicitis and vaginitis are not included under PID. So etiology, it is polymicrobial. Acute is always polymicrobial. And primary organisms, the most common is chlamydia. So we saw earlier, the most common cause of PID is chlamydia, and then gonococci and mycoplasma. Secondary organisms, so these are the primary, and then secondary infection occurs with, include normal flora of vagina, that is E. coli, group B streptococcus, klebsiella, and anaerobes. The route of spread, ascending infection, we saw in chlamydia, the most common route of spread is ascending infection along with sperm. So STI. So usually it is STI, and the only PID which does not spread this way, I told you when gonorrhea was being done, gonococci. So there is some specialty, that is TB. Sorry, not gonococci. TB, tuberculosis, it doesn't occur as a STI. Okay, so just remember, TB doesn't occur as a STI, which does not spread this way, is genital TB, which has a hematogenous, that is through blood. Hematogenous means blood. So chlamydia occurs as STI in ascending infection. One exception to this is not gonococci, just remember TB, I was confused. So TB, genital tuberculosis. And PID is almost synonymous with salpingitis. Why? Because it occurs first in the fallopian tube. So salpingitis means fallopian tube. So it first occurs in fallopian tube. Then the infection spreads. So since the fallopian tubes bear the brunt of acute infection, so infection begins. All this can become a question. The infection of PID begins in which part? Endosalpinx. And surest sign of salpingitis is pus extruding from fimbrial end of the tube. This is a key point. So what is the surest sign of salpingitis? It is pus extruding from fimbrial part of tube. So if there is pus here, it is a surest sign of vaginitis. Okay, and then Fitz-Hugh-Curtis syndrome. There is something called Fitz-Hugh-Curtis syndrome. It is PID, pelvic inflammatory disease, along with liver involvement, perihepatitis in chlamydial infection. Usually occurs in chlamydial infection. If there is PID with perihepatitis, it is called Fitz-Hugh-Curtis syndrome. So just remember H is there, hepatitis, perihepatitis, along with PID and perihepatitis. So Violin string adhesion, this is important. Violin string adhesions form between liver capsule and peritoneum. If violin string adhesion is seen in your question, just remember, just search for chlamydia. If it is there in the option, usually it is chlamydial infection, violin string adhesions. Clinical diagnostic criteria for PID. So there are three criteria: minimum criteria, additional criteria, and definitive criteria. So the minimum criteria is lower abdomen tenderness. This is how the patient will present with the symptom. And then adnexal tenderness and cervical motion tenderness. These are the minimum criteria. This should be there. And along with this, if there is oral temperature more than 38.6 degree Fahrenheit, and then mucopurulent cervical or vaginal discharges there, these are all additional criteria. Not necessary that this have to be there. And then, but these are the minimum criteria. It should be there. And then abundant WBC on saline microscopy of cervical secretions, WBC. And then raise C-reactive CRP or ESR, lab documentation of positive cervical infection with gonorrhea or chlamydia, and then definitive criteria. This is more important. Definitive criteria means if this is there, it is diagnostic of PID. So histopathological evidence of endometritis on endometrial biopsy. Again, tubo-ovarian mass, abscess on sonography or other radiological tests, and laparoscopic abnormalities consistent with PID. So we will see how PID will present in laparoscopy. How? So we will see the abnormalities. So this is the criteria for clinical diagnosis for PID. Easily it can be made into a question by, it can be all of these are diagnostic criteria of PID except, or all of these are not diagnostic criteria except. So just remember the table. Laparoscopic findings and severity of PID. The gold standard diagnosis of PID, again remember, very important, is laparoscopy. We all know laparoscopy is a gold standard for many conditions. Just make a list of just make a list of investigations and see which, for example, write down laparoscopy and make a list of which all gold standard diagnosis is there for which all conditions. One is PID, other what are all conditions are there, just make a list. And then laparoscopic findings and severity of PID. So what are the laparoscopic findings? So in mild PID, mild infection or inflammation, there is tubal edema, swelling, erythema, redness, and no purulent exudate. So there is no discharge. Exudates and are mobile. Okay, the tubes are mobile. Now moderate PID, what happens? Purulent, pus is there. Okay, so we all saw pus in the fimbrial end is a sure sign of salpingitis. So in mild, you cannot be very sure that it is salpingitis, but in moderate, because there is pus in fimbrial end, you can be very sure that it is salpingitis, and tubes are not freely mobile because of the pus. And then severe, there is pyosalpinx. This is a condition. In severe PID, it is seen completely filled with pus, and inflammatory complex and abscess. So in TB, we can see tubo-ovarian abscess, TBO. Okay, so this is the severe PID. Next, complications of PID, what it could be. If the infection is not treated, or if the inflammation is not treated on time, it can lead to peritonitis. It can lead to septicemia. Complete sepsis can occur. The infection can spread all over the body. And then dyspareunia, that is painful coition. And then infertility. So infertility is one common thing with PID, because the tubes gets blocked. And then increased risk of ectopic pregnancy. Ectopic pregnancy, one of the common cause, etiology is previous PID. Ectopic pregnancy is common. And then chronic pelvic pain. So these are the complications of PID. Next, indications of hospitalization in PID, like when can you admit the patient and when you can see as a OPD, on OPD basis. Severe illness, vomiting, fever more than 38 degrees Celsius. And then I think in the previous slide I told Fahrenheit, so it is Celsius, 38.6 degree Fahrenheit in the additional criteria. So it is Celsius. And then suspected tubo-ovarian abscess. This is there. Hospitalization, coexisting pregnancy is there. Pregnancy with PID, hospitalization, HIV positive patient, and then there is PID, hospitalization, unresponsive to OPD therapy for 48 hours, 2 days. You have treated the patient, even homeopathically, OPD basis, you have treated the patient for 2 days, yet these symptoms are still persisting. Advise the patient to get admitted, and you can give your treatment along with that. And uncertain diagnosis, the appendicitis cannot be excluded because it can mimic like appendicitis. The tenderness, the abdominal tenderness and abdominal pain, the patient that is complaining of, you are not able to differentiate, then indicate for hospitalization. The sequelae of PID, usually infertility. Infertility is the most common cause for infertility in young females is PID. And ectopic pregnancy, I told you, in again, most common cause for ectopic pregnancy is PID. Chronic pelvic pain and dyspareunia, Fitz-Hugh-Curtis syndrome. This is one of the complications where there is liver involvement, and that is perihepatitis. Just remember, perihepatitis. Next is genital tuberculosis, frequently asked question. If you take out paper of at least 2 or 3 years of AIPGT, this is asked. Most of UPSC, PSC frequently asked topic is genital tuberculosis. So I would suggest you go through the entire theory part of genital tuberculosis. And genital TB is always, it is not a primary infection. So it is not primary infection. It is always secondary to pulmonary TB. So there should be history of TB, tuberculosis in the young age. It is always secondary to pulmonary TB. Pelvic organisms involved most commonly hematogenous, blood. It is not usually sexually transmitted, so it is blood. And then most common site of genital TB is fallopian tube. Again, fallopian tube. Most in PID, the most common site that is involved in most of the PID, it is fallopian tube, because the infection first occurs in fallopian tube. So 90 to 100% in genital TB, it is fallopian tube, followed by uterus, which is 50 to 60% in endometrium. And the second most common site is uterus or endometrium, and then followed by ovary, and then cervix, vagina, and vulva. Vagina and vulva are the last to be infected with TB. So TB salpingitis, because mostly 90 to 100% it is fallopian tube, usually it is salpingitis. The both tubes are affected. It is bilateral. TB is usually bilateral, affected simultaneously. Abdominal ostium of the fallopian tube usually remains patent, and the initial site of infection is submucosal layer, that is interstitial salpingitis of the ampulla. Just remember, the question can be, there is no need that they give exactly like submucosal layer, not that very deep. They will just give ampulla, the parts of the fallopian tube. So you have to remember the initial site of infection is ampulla, ampullary part of tube. And most common pathology is endosalpingitis. And salpingitis isthmica, there is isthmus in the tube. So isthmica nodosa is the nodular thickening of the tube due to proliferation of tubal epithelium within the hypertrophied myosalpinx, that is muscle layer. And this is also seen in pelvic endometriosis. So they can give this form as a question, and they can form options like in which conditions it is seen. The conditions can be genital TB and pelvic endometriosis. Then the next options could be any other 2 conditions. So just remember, in TB and in pelvic endometriosis, genital tuberculosis and pelvic endometriosis, there is salpingitis isthmica nodosa or hypertrophied myosalpinx. And most common group affected for genital TB is 20 to 30 years, young females. And then most common symptom is infertility. Genital TB, why it is in theory also, if you see most of the theory questions, that is BHMS curriculum, OBG, most of the theory questions, genital tuberculosis is a most must-know topic. Why? Because it causes infertility in about 70 to 80%. So once the female suffers from genital TB, infertility is a sequelae which happens, and then there is permanent infertility which occurs. So that is why it is affecting the population in such a way, and that is why it is most commonly the curriculum setters, they want you to know about genital tuberculosis more. HSG findings, that is hysterosalpingography, suggestive of TB, salpingitis. So any condition that is affecting fallopian tube, you will go for HSG. Okay, so TB salpingitis, vascular or lymphatic extravasation of dye, and then rigid lead pipe tubes with nodulations at places. These are the findings that is there in TB salpingitis, bleeding and variation in filling density, and calcification of tube, and bilateral cornual block. Diverticular and jagged fluffiness of tubal outline, tobacco pouch. A frequently asked question, tobacco pouch is seen in which condition? It is genital TB. Frequently asked question, just remember, tobacco pouch. So if you go see the picture of a genital TB, I have not put here, just go through, it will occur like a tobacco pouch. So tobacco pouch means all these old people, they used to store tobacco, right? Like this. So it used to occur like this. So what to say, fallopian tube will occur like that. It looks like a tobacco pouch. So that is why, and it is a frequently asked question. Tobacco pouch is seen in which condition? Genital TB. And then dilated distal end of tubes due to hydrosalpinx and pyosalpinx. That means this is actually filled with pus. It is actually filled with pus, which looks like tobacco pouch. Okay. And then uterine cavity. Uterine cavity is irregular in outline, honeycomb appearance. So this you can see in honeycomb appearance or presence of uterine synechiae. 1 second. Okay, so honeycomb appearance or presence of uterine synechiae. This is seen in one more condition. You just go through which condition, you just see which condition honeycomb appearance is also seen. I've already dealt with that topic, so you can just go through. And then and here also in TB also it is seen honeycomb appearance. And then HSG is contraindicated if it is a confirmed case of genital TB. We will not do HSG. Why? Because there is due to fear of reactivation and spread of disease. When HSG is done, it can be reactivated. The TB which is there in one part, it can be spread to other parts. So that is why HSG will not be done if it is a confirmed case of genital TB. HSG is routinely done to detect causes of infertility. So if a female comes for infertility, to see the patency of the fallopian tube, ectopic pregnancy or after PID, what happens? The patency of the fallopian tube is gone because there is scarring. So to see the patency, usually in infertility cases, they do HSG. And the above mentioned signs may be seen in pelvic TB. Okay. Asherman syndrome, one syndrome which is added, it is DNC. DNC, dilatation curettage, is a common thing which is done on a OPD basis also. So it is the most common cause for this Asherman syndrome. The other causes are TB and pelvic infection. So we'll see what it is. It is partial or complete obliteration of uterine cavity. So there is block in the uterine cavity by adhesions, scarrings. Okay, so when excess DNC is done, so this occurs, adhesions occur, that prevents normal growth and shedding of endometrium. So endometrium is not there. So what is happening? No menses, no ovulation, so no shedding. So what happens? Infertility. So clinically there is infertility, amenorrhea, no endometrium shedding, so no menses, hypomenorrhea, and recurrent pregnancy loss. The endometrium is not able to grow and support and implant the fetus. So there is recurrent pregnancy loss or abortion. And cyclic pelvic pain. Why? Because there is adhesion and endometrium is trying to grow, and that causes pain. And diagnosis gold standard is direct visualization by hysteroscopy for Asherman syndrome. So this can be a question. So just remember, Asherman syndrome is a part of OBG topic. Don't get confused. And it is the common causes DNC, TB and pelvic infection. That is why here it is included, this syndrome. And then the main pathology is adhesions. Okay. And why there is obliteration. This adhesion causing obliteration of uterine cavity. Now the key points is, again, I'll be repeating. Okay. Theoretically, gonococcal vaginitis can occur in newborn females as their vagina is lined by transitional epithelium and not stratified squamous epithelium. In the initial slides, we saw stratified squamous epithelium is resistant to gonococcal infections, vaginitis. So, but in newborn it occurs. So, this is what I told, the speciality of gonococcal vaginitis. Okay, in newborn it occurs. Why? Because in newborn it is transitional epithelium and not stratified squamous epithelium. Now, the most common site of gonococcal infection in young females is endocervix. This was done again previously. I'm just repeating it so that you will remember better. Since endocervix is lined by columnar epithelium and not squamous epithelium, and since endocervix is lined by columnar epithelium, this is a repetition, and not squamous epithelium, vulvovaginitis means vulva with vaginal inflammation, and most common gynecological problem in prepubertal. Okay, so is non-specific vulvovaginitis. Why? Because in prepubertal girls there is increased estrogen. We saw in the few slides. Perimenarchal. Okay, perimenarch. What happens? Increased estrogen is there, and that is why vulvovaginitis is common. And risk factors of STIs or chlamydia infections, sexually transmitted infections or chlamydia, is history of previous STI, or there is contact with infected person, very obvious, and then sexually active. Female is very sexually active. Individuals below the age of 25 years, this is important because this is the most important risk factor for STI or chlamydia infection. And then multiple partners, new partner in the last 3 months, not using barrier protection, street involvement, homelessness or drug use. So why this is important? Because a patient coming to you and presenting with the complaints, you have to rule out sexually active, sexually transmitted infection. Why? Because if you know the risk factor, you will ask the patient whether these are there, whether the patient belongs to these criteria. If she belongs to these criteria, you will have to assess the patient for sexually transmitted disease or infection. Okay, and then low socioeconomic status. Among all the risk factors, age below 25 years is the strongest risk factor. Okay, strongest risk factor along with all the above mentioned. Next, 80%, as I told, 80% of women of chlamydia, I told most of the patients are asymptomatic, but the percentage is 80%, just remember. And in gonococcal infection also, there is asymptomatic, but 50%. So in chlamydia, it is 80%, and gonococcal 50%. And most common why it is repeated? Because it is an important question. Chlamydia infection is the most common cause of PID. Gonococcus is most common cause of acute cervicitis. Okay, acute cervicitis and acute salpingitis in young females, it is gonococcus. Next, genital warts during pregnancy. So what happens? Condylomata tends to get larger in pregnancy and should be treated earlier. That is, excision should be done. And C-section is done only if obstruction of birth canal or risk of extensive bleeding is there. And then vertical transmission occurs during pregnancy, leading to juvenile laryngeal papillomatosis. So if a question is formed, juvenile laryngeal papillomatosis in a neonate, what is the condition that was there during pregnancy in a female? So in the mother, that is genital warts usually. HPV cannot be prevented by using condoms. So condoms is not a preventive measure for HPV spread. And then most common cause of genital ulcers, again, this is discussed, herpes, simplex virus, herpes. Manifestation of syphilis in genital tract. So primary syphilis, it is chancre or the ulcer. This is the first stage. And then when it progresses to secondary, it is condylomalacia. And it is coarse, flat top, moist, necrotic lesion. So just remember what it is, how it presents. And tertiary syphilis presents with gamma, punched ulcer with rolled out margins. Next, tubes are not affected in primary syphilis. Primary syphilis, fallopian tubes are not at all affected. Infertility does not occur in syphilis. These are all key points, just remember. Infection or inflammation of upper genital tract, you already saw, that is PID. So fallopian tube, ovaries and uterus. Okay, that is PID. And cervicitis and vaginitis are not included in PID. Genital TB is the only PID which does not spread sexually. Okay. So just remember, again, don't get confused with gonococcus like I got confused because GG, it is not. So gonococcus, gonorrhea, we all know. Obviously, it is sexually transmitted. Okay. But genital TB is the only infection, only PID, which does not spread sexually. So if a virgin female is coming to you with PID, usually it is tuberculosis. Okay, especially with history of pulmonary TB. Usually it is tuberculosis, just remember. And most common route of spread of PID is ascending infection along with spawns. So ascending infection, and the exception here. So this can be a question. And this PID in virgin female is always due to tuberculosis. This can be assertion reasoning question. Okay. So just remember, whenever you're reading any theory part, no, you have to form a question on your own. What kind of question? Can it be a fill in the blanks? Can it be a assertion reason questioning? Can it be a statement question? So you have to, there are, if you go through the question papers, there are 10 types of questions. So what you have to do, effective learning, when you're learning theory, don't just read. You form these 10 types of questions. You see, tubes are not affected in primary syphilis. This is a very good chance for the fill in the blanks kind of question. That means direct question. It is a direct question. Okay, but here PID in virgin female is always due to tuberculosis. Why? Because it does not spread sexually. So this is assertion. This is the reason. So you have to make sure you have to form questions. Okay, this way. And then most common route of spread of PID is ascending infection except TB. So there are included except, or only one is included except all. Okay, these are two types of question that is formed. So you can make questions from the theory part like that. So that will be effective. Why? Because you will remember better. And Fitz-Curtis syndrome, again, hepatic adhesion. So involvement of PID plus liver. Okay, and it is usually chlamydia. And investigation of choice for PID, diagnosis is laparoscopy. Again, this is gold standard. Okay. And then surest sign of salpingitis is pus extruding from fimbrial end. Again, repeating. Violent string-like adhesions. I told you, if you find this, search for chlamydia. So in the option, so chlamydia infection, and this is usually seen in Fitz-Curtis syndrome. Infertility results from tubal as well as endometrial disease. Okay, and tubes may be patent on HCG, but there is functional loss. So if you do HCG, infertility patient has come, but tubes are patent. So you will get confused. But here tubes are patent. There is no much scarring is seen, and it is proper tubes. But functionality, okay, anatomy is proper, anatomy is good, but functionality is lost. And percentage of TB patients that are infertile. So now in 100 patients with TB, okay, genital TB have come. How many patients will be infertile? 70 patients will be infertile. Only 30 patients you can be like, okay, they have not bore the brunt of this infertility. Now, percentage of infertile patients. Now 100 infertile females are there. 100 infertile females are there. Okay, and then what is the among this 100 females, how many have TB? Okay, so you have to remember, always don't get confused. So this is a different criteria, this is a different criteria. In 100 infertile female, now how many have TB? That is, in worldwide 10 females will have, that is 10%. But in India it is 17%. 17 females will have TB. Okay, so don't get confused about the percentage here. Now, most common vaginitis in pregnant women, again, candidiasis. Vaginitis in young females, it is trichomonas vaginitis. And causing candidiasis is Candida albicans. And most common site, again, repeated, endocervix for gonorrhea. Strawberry vagina, again, trichomonas vaginitis. This is repeated again and again because you have to remember no matter what. Curdy white discharge or cottage cheese-like discharge. First initial slides we saw candidiasis, whiff test positive or Clusels or Ansell's criteria. See, this can be one of the question where it can be formed. Again, they can add one more criteria or one more examination and be like which and all include the diagnosis of bacterial vaginosis. Okay, so this is bacterial vaginosis. Whiff test, one is, that is 10% KOH, or again amine test, and Clusels and Ansell's criteria. Genital warts, again HPV 6 and 11, and that is condylomata acuminata. Cancroid, we haven't discussed much in detail about this condition, but just remember chancre is syphilis, cancroid is Haemophilus ducreae. Remember the organism, important. Next, investigation of choice for chlamydia is NAT is more than PCR. Okay, PCR is done in others. After treatment of genital TB, of the patients who conceive, 50% have tubal pregnancy. So this is why this is an important threat or a problem for the public. Okay, whenever a condition is such a problem for the public, it will be included in both your theory and competitive examination, because they want you to know about the condition. Okay, 50% have tubal pregnancy and 20 to 30% abort. Okay, among the whoever conceive, and 2% have, only 2% have live birth. That means you can imagine a patient with genital TB is a very such an unlucky patient. Only 2% will have live birth. Okay, others are either tubal pregnancy or abortion. So this completes pelvic infection. It was very lengthy topic. And then next topic is PCOS. Okay, very important. One question for sure. Few papers have 2 questions also. Okay, for sure in your paper, because most common condition that a young female is suffering from in this scenario is PCOS, genital condition. So that is why gynecological condition. So that is why it is included in your paper. So it's old name. So first it was PCOD. Okay, so the old name of PCOD was Steen and Leventhal syndrome. Now the new name they have converted as PCOS, polycystic ovarian syndrome. Okay, so just remember the name, Steen and Leventhal syndrome, because these were the people who found the condition. And it is characterized by amenorrhea, hirsutism, that is hair growth, obesity, weight gain, polycystic ovary. So these are the presentation of a PCOS patient. And then heterogeneous disorder. Why? Because you can see amenorrhea, hirsutism, obesity, polycystic. Okay, these 2 are somewhere related, but these 2 are not at all related. The pathology is related, yes, but completely that is why it is called syndrome. Completely different pathophysiology is occurring in a female. That is why it is called heterogeneous disorder. It is characterized by androgen. Just remember, androgen excess. It is a condition of hyperandrogen production. Okay, hyperandrogenesis, excess androgen production by the ovaries. So androgen, we know many places is produced in a female, but ovaries also have this capability of producing androgen. I had told in the first classes when anatomy and physiology was dealt. So androgen production is increased in PCOS, and that is where the entire pathophysiology comes. And multifactorial. It is not due to only one cause. There are many causes involved in it, and polygenic, many conditions. So incidence is 0.5 to 4% common among infertile women, and age is young reproductive age group, 20 to 30%. Okay, it is young reproductive age group is the age. Diagnosis, any 2 of 3. So if you remember the criteria for diagnosis of PCOS, it is called Rotterdam criteria. Very important question, asked frequently in competitive exams. So Rotterdam criteria, what it is oligomenorrhea, or it is actually, this is not menorrhea, and ovulation. Okay, so oligomenorrhea and or, okay, and oligomenorrhea and or anovulation. So it is usually anovulatory cycles in PCOS. Okay, anovulatory cycles. That means ovulation is not occurring. Okay, and then hyperandrogenism. Hyperandrogenism means there is an increased androgen state in the body. It can be clinical or biochemical. The clinical, it is in the form of hirsutism, acne, or alopecia. So hair growth or pimples or hair fall. Okay, alopecia. Hirsutism means it is hair growth in certain places. Alopecia, hair fall. Okay. And then biochemical. So this is clinical. Clinically, if this is the presentation. And then biochemically, if serum testosterone. So androgen excess means testosterone should be high. Between 70 to 150 nanogram per dl. Next criteria. So Rotterdam criteria is 3 criteria. Just remember. 3 criteria in Rotterdam criteria, and among this, if any 2 are there, then you will diagnose it as PCOS. So next criteria is polycystic ovaries. Okay, usually all the 3 can be present. And in polycystic ovaries, how it is seen, it is 12 or more cysts. This is very, if you go see the question paper, this will be there. How many cysts? 12 or more peripheral cysts. Okay, peripheral cyst in the ovary. Just remember, peripheral cyst in the ovary. Sorry. Peripheral cyst in the ovary, and then both or one ovary. It can be bilateral or unilateral, and ovarian volume is more than 10 ml. Okay, so quickly we'll see. Ovaries are enlarged. Ovarian volume is more than 10 cubic centimeter. Stroma is increased, and capsule is thickened and pearly white in color. And presence of multiple cysts. So more than 12 follicular cysts, and this follicular cyst is in different maturation stage. One is in one maturation stage, and next. So they are not in a proper maturation, uniform maturation stage. Measuring about 2 to 9 mm. Each cyst can be measuring about 2 to 9 mm in diameter, crowded around the cortex. So histologically, thickening of tunica albuginea. Cysts are follicles at varying stages of maturation and atresia. So usually it is atretic follicles. And theca cell hypertrophy, stromal hyperthecosis. Clinical features: obesity, abdominal obesity. If the patient comes with 50% abdominal obesity, if the patient comes usually with amenorrhea and other criteria, usually it is PCOS. Menstrual abnormalities in 70% of cases. In 100 females with PCOS, 70 will have menstrual abnormalities, and that menstrual abnormality is usually oligomenorrhea or amenorrhea. Usually this is more common, amenorrhea. And then DUB in few, and then infertility and hirsutism and acne in 70% again. It is seen. Virilism is rare. Even though if it is a hyperandrogen condition, virilism is rare. And then acanthosis nigricans is a condition which is seen in PCOS. Specific skin change due to insulin resistance. Insulin resistance is something which is seen in PCOS. And then there is thickened skin. There is pigmented skin, that is gray-brown. The sides are nape of neck, inner thighs, groin, and axilla. Hair and syndrome. So hair, HAIRAN. So this is hyperandrogenism. IR is insulin resistance. AN is acanthosis nigricans. Hair and syndrome is these. With just remember, don't try to read more about it. Just remember with the name. Hair and you read about it. That is no issue. I'm telling how to remember this. This is how you will remember with PCOS. Don't forget PCOS. Okay. So along with PCOS, if this is seen, it is hair and syndrome. Investigation, sonography, transvaginal sonography is done in obese patients. Okay, abdominal sonography will not show the clear picture in obese patients. So in TVS, what is seen? Ovaries are enlarged in volume more than 10 cubic centimeter and more than 12 peripherally arranged cysts, which is 2 to 9 mm. Always remember the measurements. And string of pearls. Okay, so this is important. How it is seen? String of pearls. It is seen like a string of pearls. Laparoscopy, bilateral polycystic ovaries are seen. Serum values. So it is investigation. Either it is sonography, along with sonography, serum investigation should be done. So serum value, just remember, LH is increased. Okay, and LH-FSH ratio is more than 2.1. This can be made into question. It is asked in the question. So raised level of estrogen. So 1 second. I'll do it here. LH is increased and estrogen is increased. Estrogen is increased and then SHBG, okay, is increased. SHBG is sex hormone binding globulin. Sex hormone binding globulin is, sorry, it is reduced. Not here. It will come here. SHBG is reduced. Okay. Hyperandrogenism. Androstenedione is increased. Androstenedione is increased. And there is something called DHEA. Dihydroestrogen. Okay. That is also raised. So, SHBG is decreased. FSH is decreased. My point is just make a table like this, which and all is increased and which and all is reduced, so that they can easily form a question with more than four options like this. In serum values or in PCOS, which is increased, which is reduced. Okay, so just make sure like that. Next, raise serum testosterone. So testosterone is increased and DHEA is maybe marginally elevated. And insulin resistance is seen. In that, fasting glucose insulin levels is more than 25 and fasting glucose insulin ratio is less than 4.5. That means insulin is high. The serum insulin is high and it is not being taken up by the body. So insulin resistance is there and you can see more insulin in the body, glucose in the body. Levels of serum insulin response more than 300 at 2 hours post glucose load suggests insulin resistance. Okay, so these are the serum. And pathophysiology, hypothalamic pituitary compartment abnormality, androgen excess, and ovulation. So what happens? So there is GnRH. This is all related to the positive and negative feedbacks. So what happens? The cause for it, exact cause for why GnRH is raised is not known. So GnRH is raised, which will influence the LH increase. So LH is raised. So leptin, insulin resistance, and hyperandrogenemia is the cause that is related to why GnRH increases. That is same. And it is preferential to LH. Always GnRH is preferential to LH than FSH, and that is why LH is increasing. Okay, and then increased pulse frequency and amplitude of LH results in tonically elevated level of LH. So here anovulation is one condition which occurs in PCOS. So we know ovulation, during ovulation LH surge occurs, sudden rise of LH. But in PCOS there is tonically elevated. This you have to remember. That means slowly LH is rising. It is not sudden rise only for ovulation. So that is why ovulation is not being able to happen even though LH is high. FSH is not increased. This is due to the negative feedback effect of chronically elevated estrogen and the follicular inhibin. And estrogen is increased due to reduced sex hormone binding globulin and positive feedback relationship of LH. So LH is increased and it affects the ovary, and then estrogen is increased. And LH FSH ratio is increased. Okay, so LH is higher than FSH. So here you have to remember luteinizing hormone. Okay, luteinizing LH is increased. Altogether it is increased. Next, androgen excess. Androgen forming enzyme. There is one enzyme which will come in the next slide. This is increased. Abnormal regulation of androgen forming enzyme is thought to be the main thought again. Exactly the pathophysiology behind PCOS is not known to be the main cause for excess production of androgens from the ovaries and adrenals. Principal source of androgens in a female, it is ovary, adrenals, and then systemic metabolic alterations. So more occurs in is most common is causes in ovary, androgen excess. Ovary, there is theca cells. This is what I was telling. There is something called theca cells in ovary, so which has the capability of producing androgen. So what happens? This theca cells is usually not stimulated. In the normal physiology, theca cells exist. They produce slight amount of androgen normally, but this high LH goes and stimulates the theca cells. Okay, which has receptor cells for LH, and that is why it is getting stimulated. And then once it is stimulated, it produces androgen, high androgen. And this is the enzyme P450C17. Enzyme hyperfunction, defective aromatization of androgens to estrogen, stimulation of theca cells by IGF, insulin growth factor. So it is not only one factor, only LH is not responsible for the theca cells to be stimulated. It is insulin growth factor because of the insulin resistance. And then adrenals. So adrenals, what are the causes? One is stress. Once the female is very stressed, androgen is increased. Okay, and then P450 again, C17, enzyme hyperfunction, associated high prolactin level. So if a female has prolactinemia, high prolactin levels, then androgen is increased. So hyperinsulin, systemic metabolic alteration, hyperinsulinemia occurs. Again here, that is because of stimulation of theca cells. Insulin results in more free insulin growth factor 1, and by autocrine action, insulin growth factor 1 again stimulates theca cells to produce more androgens. And insulin inhibits hepatic synthesis of SHBG. It inhibits sex hormone binding globulin. And what happens if it is inhibiting? It is not binding. Sex hormone is not binding with anything. So then it becomes free levels of androgen is excess. And then insulin resistant. How will you diagnose insulin resistant? One, BMI should be more than 25. And then acanthosis nigricans. And then waist to hip ratio more than 0.85. These are the diagnostic or the presenting features of insulin resistance. Okay, so not all PCOS case can be with insulin resistance. Okay, usually it is with insulin resistance, but if there is insulin resistance, these criteria should be present. Next, hyperprolactinemia, mild elevation of prolactin is occurring, and increased pulsatility of gonadotropin releasing hormone or due to dopamine deficiency or both. Why it occurs? Because of this. And prolactin, what it does? Again, it goes to adrenal androgen production. So prolactin stimulates the adrenals to produce androgen, and that's why androgen is high. Next, anovulation, why it occurs? We all know LH is high, but FSH is not there. Okay, so follicle stimulating ovary is not there, then maturation of Graafian follicle will not occur, right? If Graafian follicle is not matured, it's not ruptured, and it is not formed into corpus luteum and ovum, release of ovum. Okay, this is the end product of ovulation, corpus luteum and release of ovum. So this is not occurring, then obviously there is no ovulation. So follicular growth is arrested at different phases of maturation, and where atresia is occurring. Okay, atresia is occurring. The follicles are going into atretic stages. They're not going into maturation, proper maturation. So they are just in different phases of maturation. And then the net effect is diminished estradiol. Okay, and increased inhibit production. And then elevated LH, there is hypertrophy of theca cells. Again, more androgens. And then defective FSH induced aromatization of androgens to estrogens. And this is very important. Follicular microenvironment. Okay, follicular microenvironment in the ovaries. The follicles should undergo maturation and then forming into a Graafian follicle, again going into ovulation, again going into corpus luteum, and then ovum being released. All this should occur. This is a follicular microenvironment. It is becoming more androgenic in PCOS rather than estrogenic. It is estrogenic, but it is becoming androgenic, and that is why no ovulation is occurring. And there is atretic follicles. So because of hyperthecosis, there is atretic follicles, and that is why there is no ovulation. Ovulation is not occurring. So this completes PCOS. So the important points I've covered. So whatever, just go back to your textbooks and study materials and just go through and then make your own notes and then